As everyone's joining, I just want to welcome you today. This is Hand Therapy Briefs. My name is Morella Deischer. I'm the founder of Virtual Hand to Shoulder Fellowship. For those of you that are newer and don't know much about VHSF, this is a didactic curriculum in hand therapy. We offer curriculums to meet the needs of different learners that are interested in specializing in hand therapy, with the fellowship, the one-year fellowship being really the focus of our attention. This is, again, to help generalist therapists, whether you're a PT or an OT, specialize. And hand therapy briefs are weekly sessions that we've been doing for the last several weeks. We have a few left, and we've had some great discussions. And today I'm really excited to have Mike Mueller of Rothman Orthopedics. He's a certified hand therapist, and his specialty is working with the injured athlete. So I'm going to just ask you, Mike, if you can share a little bit about your clinical backgrounds, kind of the history of what led you to having this athletic focus.
Sure.
We can just start right there.
Okay. Well, thank you. Thank you, and I'm happy to be here. I originally, again, I'm an occupational therapist. I also have degrees in training in exercise science as well. And I have been working with athletes for over 30 years. And I went through it kind of backwards. I treated professional and college athletes first, and then got more involved with some of the younger athletes in addition to the pro and college around 2001. So I've been kind of developing a lot of the things that I do around the various the various age group of athletes now too, not just the pro and the college, but also into the youth. I work at Rothman Orthopedics, so I work closely with hand surgeons, shoulder elbow surgeons, operative sports medicine, and non-operative sports medicine. So I get a very different flavor of that. And then we are the physicians and the staff for professional teams, college teams, and then local high school teams as well. We're in the Philadelphia region, New Jersey, New York, and Florida. And I am housed in the Philadelphia suburbs.
So how did you develop this expertise focused on athletes?
Okay, so the very first athlete I treated in the OT world was on my level 2. I was in New York City. They actually had an NBA player that had been injured, and I was studying under a hand therapist. There wasn't such thing as CHT back then. This is going back to the old days. This was an occupational therapist who specialized in hands, and that I became an OT. I thought I wanted to be a pediatric. I had no interest in hand, didn't know hands. And between that experience and our advisor was Jane Bear Lehman, and she was one of the founding members of ASHT. And so I was able to, I got pushed in that kind of direction and then really fell in love with it. So that was my first experience. And then my first job out of school in New York City, I was still an athlete myself. And so I was training after college, and so there were some athletes coming in the clinic, and more of the therapists I worked with were more into the arts and some of the other things, and they were like, "Hey, Mike, how would you like to do some training and some teaching within the sport?" So that's how it started a very long time ago. And then I did some specialty work. I did some specialty work in strength and conditioning too, on top of that, to kind of fill some of the gaps I had in my knowledge so that I would be able to address the entire athlete.
And what kinds of injuries are you commonly seeing? Can you talk a little bit about common injuries, but also are there patterns associated with different sports?
Sure. So I would say right now, this is a wonderful time to be a hand therapist in the sports world. I actually feel I've been doing this for over 30 years, and I feel like I'm in more demand than I've ever been. Some of the exercises that we do as hand therapists in the hand world, they're starting to find that there is a need for those kind of exercise, and even in injury prevention and in exercise enhancement, sports enhancement. So if I have been requested, a lot more people have been in contact with me than I ever remember with that. I would say the most common injuries, if you're talking the hand and the wrist and the elbow, are still acute injuries first, where the fractures. This summer, the big injury pattern was intra-articular, and it was among all the sports. Inter-articular fractures, especially the IP joints. I saw it with everything from lacrosse to cricket to baseball to basketball to football. That has been, and that's why I always encourage hand therapists. Many of the things that you see in your clinic, in your normal thing, those are often the injury patterns that happen in sports. And it's for OTs, especially, I try to talk to them like, this is another occupation, the occupation of sport. And then we also see, like everybody else, we see athletes, the weekend warriors. There's injury patterns with that as they age and they want to continue to do the same sports. We see some more sprains and strains and things like that. Because I'm so involved with baseball, I see a lot. I also see a lot of elbow and shoulder. And baseball is where I probably see the most injuries personally. But again, it's probably representative of all sports.
So with the injured athlete that's a competitive athlete, I'm curious about how that looks different, the rehab process compared to the non-athlete who has the same injury. What are the kind of unique considerations related to the fact that they're an athlete without their desire to return to play? How's that also incorporated into care? I'm just going to go ahead and mute.
Okay, I might have missed it.
Mike, just unmute yourself. So my question, because I think I got cut off by a little background noise, was just the difference in rehabbing the athlete as compared to the non-athlete with the same injury, how it looks different.
So the things that are definitely different are, number one is the kinetic chain approach, where I'm using a lot more of the more proximal structures, looking at the entire athlete. And one of the things with working with athletes, number one, is we try to we want to introduce the sport as soon as possible. So even like some of our early when the patient is in a more acute phase, I'm using so say they're there for a thumb injury and I need to work on range of motion. I'm actually using the ball itself to do some of those stretching, things. I do more functional analysis in terms of movement. So nowadays we walk around with these wonderful things in our pockets, and my athletes will bring me video of their sport and what they do, particularly in their sport. I just recently had a Division I female lacrosse player. She gave me a lacrosse 101 for her position and showed me everything she needed to be able to do. She had a torn medial collateral ligament and we needed to rehab that. So I also think we are learning more and more utilizing neurocognitive strategies. I know we call that other things sometimes in other realms of hand therapy, but in treating athletes, I do a lot of reactive and cognitive type things. And I would also say the other difference with rehabbing athletes is I tend to use all energy systems. So as hand therapists, we're often all very comfortable with things like active range of motion and isokinetics and things like that. With my athletes, I am moving more into the ability for endurance, their ability to perform the sport specific task with the demands of it. So I'm trying to create an environment that is controlled chaos. I'm introducing them to stress as much as I can simulate the athletics, and I'm controlling that stress so they can be successful and be able to gain that confidence physically, psychologically, neuromotorically, so that they can return to that sport. And I think that is, in my experience, is maybe perhaps a little different with athletes. I'm not at the table as much.
Yeah. So regardless of the nature of the injury, you would go through that process as their transition back to sport for sport readiness.
Correct. Yeah. So I do a sport-specific evaluation. So over the years it's developed. I had my key sports first, and where most of my referrals came from: baseball, football, basketball, wrestling, gymnastics, fencing. You know, that when I first started, those were the sports that I had the most referrals. So I would take elements of those sports and include that into their evaluation. And then from that, as I progress them, I'm progressing them on the importance elements of their sport. So that often requires me to do some functional movement analysis. I'll see how their whole body moves. And because they've been injured for a period of time, the last thing you want is for an athlete to go back for with a distal radius fracture, and because you were just really working on the distal radius fracture, but not putting them through other types of whole body movements and training, or coordinate that with their strength coordinators or their school staff, you know, they can be re-injured. And I learned that myself. I was rehabbing a knee injury myself as an athlete, and ended up tearing an abdominal muscle because as I was being rehabbed, they were really only focusing on my knee. And when I got the clearance to go back and start doing more sport-specific type tasks, it actually delayed my return to play by 4 weeks.
So having said that, then, you know, obviously you have this high level of expertise in working with athletes, so you could do a lot of the play readiness type workouts. But with regards to working with other members of the team, because there's athletic trainers, there's individuals involved in that person's athletics on the other side of healthcare, how do you interact with them?
Okay, so you know, everything is a little different. Sometimes it depends on their level. Like obviously our professional athletes, there's actually more players involved. You know, we have coaches, their position coaches, we have their medical staff, whether there's the general medical staff, the surgeon, the athletic trainers, and that aspect. But you know, the day-to-day operation, most of the athletes, the key players are the athlete, often a coach. Sometimes the athletic trainers that you're dealing with, from whether it's their high school level. We out here in Pennsylvania, we have athletic trainers now in the middle schools as well. You're dealing with parents, and that is also if I had $1 for every parent that has told me that their 13-year-old is being recruited already in college, I could have retired 10 years ago. So there's those demands. I mean, I also need to often communicate with nutritionists. I have communicated with a wide variety, and that's one of those things. One of the things I love about working with athletes is in orthopedics, it's a true team sport, and I like that element of it. Like I like working with the other providers and support staff and whatever the case may be, to give that, to work for that overall picture of getting the athlete back.
So since you brought up like kind of the pediatric population and school-aged athletes, have you seen any changes with regards to injuries amongst younger people? Because it seems that they're playing sports all year round, so that we're not seeing a lot of like cross training. They're often involved in the same sport, playing maybe on multiple teams.
Right.
Have you seen any kind of changes with like the incidence of different injuries with younger?
Yes, absolutely. That's what set me off in this journey in 2001. I had a Major League Baseball player with a Tommy John injury, and I had a 15-year-old, my first ever 15-year-old with a Tommy John injury. And I would say since 2001, the injuries in our youth participants has grown and grown and grown. And at Rothman, we did a research study. We were involved in a research study where we actually found that early sports specialization is one of the #1 reasons why injuries occur. If you look at, you know, injury patterns, we see that. And I worked for years never treating a little league elbow. I treated 4 last night. I had 4 in my clinic last night between 4 and 7 p.m. I worked a very long time for never treating little league shoulder, and I had 2 in my clinic last night. And no one specializes earlier than gymnasts. Gymnasts are and they add other challenges by often being and when they're young, being super having some of these hypermobile joints, and you're adding stress to these joints, and that is challenging. So I think you hit on a very key point, and that's where, as hand therapists working in the community, if you're working in a general hand practice, these patients are coming to you, and they're coming with sometimes a diagnosis of elbow pain or shoulder pain or wrist pain. We're seeing an increase now in stress fractures in the wrist in very young gymnasts. And so this is an opportunity to not only rehab, but make some change, help them make some changes. Some athletes are going to specialize. That's going to happen. It's a tough battle. But even if you can get young people to do play patterns, like go and play pickup soccer with your friends and move in another direction, educate the parents to do that. We do a lot of education with our parents when they come in, like on my baseball specific evaluation. Right away, when they're filling this out, I can tell their level of specialization, how many innings they're pitching each year, how many different teams do they play on, are they playing tournament? One of the injury trends we've seen in baseball, the more you participate in events, where these recruiting events, the higher chance you have for shoulder and elbow injuries, these type of things. So I'm in the last few years through ASHT, I've done more lectures on some of the younger athletes to get the word out to the community practicing hand therapists, because often you can identify these things and make changes at an early age that will allow them to be able to do the sport that they want to do, that they love, for as long as they want to do it.
So you mentioned prevention type programs.
Mm-hmm.
How would they look different for the younger person as compared to the older athlete?
Okay, so for the younger person, again, we're talking about educating about specialization. Number 2 is developing good movement patterns. Like, let's take, for instance, let's talk about a 12-year-old. All right, here's a 12-year-old who comes into my clinic who has a diagnosis of little league elbow, and I do my hand therapy evaluation, but I also do my functional movement assessment, and I see this 12-year-old who can't get into a deep squat with their hands over their head. They can't transition with good hip separation, going from laying down on the floor to standing up. Well, I can include that type of movement in the clinic with that. And there was a great article that came out 2 years ago by Kevin Wilkes' group called the Youth and Adolescent Throwers 10. And take away the throwers part of it. This works very well with all your young upper extremity athletes, because it integrates their lower extremities with their upper extremities. It pays close attention to the core and the trunk. And so a lot of those preventative strategies around that, I also will tell them, it's important, if you look at the key lifts as in terms of weightlifting in sports, in a musculoskeletal immature athlete, we should not be adding heavy weights into those positions. I always tell these parents, the best thing you can do for your child is to teach them how to move without weight in those patterns. Do a squat, do a deadlift, but with no weight. If Mike Mueller got to become king of the world in terms of upper extremity sports performance, he would have every young person learn how to do a perfectly executed push-up. There's no better exercise than that. And we've learned some other things, like from Mike Reinold's group and some of these other groups, and some of these prevention in the young athlete is even working in prone and paying close attention to the Y and the T position and the I position. So I try to integrate that early. And unfortunately, like, one of the injury patterns I've seen is they see me. I've been in this same area of practicing for over 21 years. So I have had kids that I have seen when they're 12 for Little League elbow. And then I'm thinking about one young man right now who's pitching in college. And I saw him again when he was 15 for shoulder soreness. And then I saw him again when he turned 18 for a Tommy John procedure. And so, you know, this raises that when you practice in an area, and you get to see some of these patterns happen in real time, and they're concerning. And I think as occupational therapists, physical therapists, and hand therapists working in the community, we can be a resource to these. And I did, and if anybody wants a copy, I did a lecture last year at ASHT on how the hand therapist can be a resource in their community for youth and adolescent baseball. And, you know, I'm happy with Morella. You could share my email, and I'm happy to send people a PDF, because that information needs to get out there. And the other important type thing again is for them to have off seasons, have them have an off season. It's important.
What about like psychosocial sequela? You know, one of the factors that you're dealing with. You know, an athlete's injured. How does that factor into their recovery? And do you incorporate anything on that level with the rehab process?
I do, and I've actually, the longer I do this, the more I'm incorporating it. And I had an athlete this year who was referred to me. He's a college baseball player. He was referred to me by one of my colleagues. He had elbow, and he had elbow surgery for the medial elbow and the ulnar nerve. He had actually been so depressed about not being able to play that he actually had a suicide attempt, and fortunately survived it. And the clinician said, there's something more going on with this person, and referred him to me because he knew that I had specialized in that. And I did an assessment and actually found by learning these things that it was really more his brachial plexus. But the most important thing was I was able to give him an answer and coach him psychologically that we're going to get you better. And I used a lot of the psychosocial component, and it was amazing the change in this young athlete. And, you know, he went back this year, finally being able to play baseball after being out for 2 years. You know, his whole affect has changed. His mother didn't have to keep coming with him to the clinic anymore. We were able to really, so I use a lot of the psychological, I do a lot of my reading, a lot of my own personal professional reading in the sports psychology now to learn better about. I mean, I went to OT school in the Stone Ages. So I needed to come up with some more up-to-date psychological type of thing. So I have found that. I also find sometimes that's one of the things I like about my clinic. A lot of the athletes come from 3 to 7. And they're in there together, and they're motivating each other. I mean, I have a video of a lacrosse player, and it's the first day I'm removing his post-surgical, and I'm having him move, and you see his body language. He's very sad, he's very upset, and all that. And within that visit, I make him a guard and allow him to put the lacrosse stick in his hand and the ball and do some things. And it doesn't even look like the same kid. He's smiling from ear to ear, and that aspect. So it is a key component. And when athletes are injured, they're on the depressive scale. I mean, if you read the literature, I mean, their depression, their anxiety, to get back and to do those type of things, they are going through the stages of grief, stages of that loss of identity. So yeah, then that's why I'm a big believer in putting the sport in as early as possible. That's their role, and that's what they know. Do it as early as possible, and communicate, like, we're going to get you from A to Z to return you to play. And there's going to be times where you're not going to feel good, and you're going to need to tell me, and I'm going to adjust that. And we're going to adjust that, and then we're going to get you back. But we're going to build your confidence throughout that process. So yeah, more and more. I wish I would have known more about this stuff in the 90s and the early 2000s, but that's why we're always doing self-evaluations, seeing where our skill gaps are, and then finding ways to improve those skill gaps.
So I don't see questions. With the remaining minutes, I do have a question myself. I'm curious about how your knowledge of working with the athlete has altered the way you treat the non-athlete.
Oh, absolutely. Like, no, I'll give you one example, tennis elbow. Like I have the way that I treat my tennis elbow patients more and even wrist tendinopathies. Generally speaking, the tendinopathies, I use a lot of my whole body kinetic chain types of exercises, activities, training people for the true demands of what they need to go back to. There used to be a saying, focus on being interested, not interesting. And if you're interested in the patient, they will tell you what they need to go back to do their work, to do with the things that they love. And then I can factor those, okay, what energy systems, what movement patterns do they need to have to do that? So I apply that more and more to my non-athletes as well. Definitely.
I want to give our attendees the opportunity to ask any questions. So if you guys have a question, please, go ahead and post it in the chat. Definitely working with athletes and the use of that focus of the kinetic chain, I think has developed this skill that I would imagine would translate to treating all patients, because we can't dissociate the upper limb from the rest of the body.
Yeah.
So to end, can you advise people just treating, even whether it's an athlete or patients in general, a way to approach learning to understand more about the kinetic chain so that they can maybe incorporate more of a whole person approach to physical rehab? Yeah,
sure. I mean, not that the way that I did it is the only way to do it, but like I started with the upper extremity kinetic chain. I spent a lot of attention going from the fingertips to the scapula, and then I learned, when I learned a lot about the scapula, then I moved a little more proximal, and then I got more comfortable with the thoracic spine and how it relates to the scapula. Then I dropped, and then I went into the trunk, and then I went to the hips, and then the last probably 10 years I moved down to the ankle. So I think trying to learn the entire thing is tough, but I think that I think a great way to learn it, and I had mentioned this at ASHT, if you learn the squat and the deadlift, okay, and you look at the muscles involved in those two activities and the way they're performed, and now with all our virtual learning opportunities on YouTube and all that, if you learn those two and really learn that aspect, those two important lifts, you can easily then expand into other areas of the kinetic chain. I do think it requires study, it requires reading. My reading is pretty broad based. I read a lot. I obviously read the hand journal and the hand surgery journals, but I read the American College of Sports Medicine's journal. I read there's the Journal of Shoulder Elbow Surgery, has a lot of great sports specific stuff that goes a lot of the hip stuff that I learned was from reading that journal as well. There are, I have no financial with FMS, functional movement screen. They have some wonderful presentations online that can teach you how to analyze movement, and they're not cost prohibitive. You can do them virtually, you can do those live. I think finding mentors, like I went and visited people early on and learned from. I continue to learn from people. I think I look at my level when my level 2 students come in. How do they seem to learn it best is taking it in small bits as it relates to a specific sport. So I think when they're seeing it a lot with baseball, they get comfortable with that one sport and learning how to apply it. So I know it's kind of a verbose answer, but that's what I would recommend.
Wonderful. One question popped up in the chat.
Sure.
I think we could squeeze in. Question is, with a distal radius fracture, at what week post-op or conservative management do you allow push-ups?
If we have quite a few hands, so this is always a debate during surgery fellows conferences. When do you put weight bearing on a post-operative distal radius fracture? And I'll tell you how I decide on allowing someone to get to do a push-up on their distal radius fracture. So it's generally speaking, I would say as we begin weight bearing, depending on the needs and depending on the fracture, it's somewhere in that 6 to 8 week post-surgical period of time. But we test, one of the things that we're working on here at Rothman is some sport-specific upper extremity testing and things like that. So I actually do a tabletop, that article that appeared in ASHT, where you could do the weight-bearing test with the Jamar dynamometer. And I have them press down to where, and they tell me when they get to start to feel pain. And if they feel pain at 40 pounds, then I start the weight bearing process at 20 pounds. And the first few times we'll do that, it may be an adapted position. I may have to have they have weight on their knees and they have weight on their uninvolved hand, and they're gently pushing into the scale to get that rating. And then I'm adding to that at each interval that I see them. And then once they can tolerate that, then we go to the wall. They do a push-up against the wall. When they can tolerate that, then we do an adapted push-up where they're on their knees and they're taking the weight bearing across all extremities. Then we go from there. They do the star position. So they're on a mat table. They put all the weight on, they go from having it all on 2 hands, they go to 1 hand. If they can tolerate that, then I allow them to start doing a push-up. And I think it's important that you have a process and not necessarily a timeline. I appreciate the question because we often get timelines, but one of the things that we're trying to, in upper extremity sports medicine is talk more about functional milestones and not just timetable milestones. Is looking to see if they can do A, B, C, and D, then they're able to move on. I mean, if you have a professional level distal radius fracture, like I had an NBA player distal radius fracture, obviously I'm adding weight bearing in an earlier period. This is somebody who's getting hand therapy and ATC therapy. That's their job, and they're able to weight bear at a much earlier element, but they still have to accomplish A, B, and C before they can move on to D. And we need to have that. That's the kind of thinking that you want to use with your athletes, is develop a system approach and start with the common injuries that you have. If you see more hands, you see more wrists, you see more elbows, start with those. Look at the sports. All that data is out there. The injury trends are out there. Find those sports and develop that functional process for you. So I wasn't trying to duck the question, but like Morella knows me, I'm all about the why. And the why is, why you're doing it. And then you move on to the how you're doing it. Right. I want to see them meet certain milestones before I add weight bearing. And then also, what does the sport demand? Okay, a wrestler with a distal radius fracture needs to be in the bottom position with another athlete of equal weight on top of them, and they need to be able to weight bear and get off with not only with their weight, but also that their opponent's weight. A gymnast may have all their weight on one hand, and twist and turn and be moving and then landing on that one hand and doing that. So you need to understand the sport's demands as well. So you develop functional milestones and how you progress people through the process. And my general way of doing it is I look at the rehab process. Stage 1 with athletes, stage 1, stage 2, stage 3, stage 4. Stage 1 is that acute phase where we're all real comfortable working. Stage 2 is when we start working more on that whole body and elements of their sport. More of the elements of their sport is being involved. Stage 3 is that's when now they're doing plyometrics, more sport specific drill, more weight bearing requirements that require that sport. And then they might actually start doing a little bit of sport interval rehabilitation. And then phase 4 is the return to sport phase. And that's where, let's take the baseball player example. That's where they're doing a tossing program, a long tossing program. That's when they transition to a mound program, or if they're hitting off a tee first and then they're transitioning to live hitting in that aspect. So that's kind of the broad stroke, the broad strokes. And I have functional milestones that I want to see within those periods to go from phase 1 to phase 2 to phase 3 to phase 4. And those are communicated early on with the patient and frequently with the patient, because we all know people hear what they want to hear. So I keep saying it over, you're saying it over and over, and I'm communicating that to the parent. I'm communicating that to the coaches. I'm communicating that with the physicians. I'm communicating, here's where we are. And that's where, again, having those functional milestones. And that's one of the things that I've really put a goal on myself, a personal goal this year, is to really try to get more talks out there on for hand therapy. Kind of, here are some of the functional metrics we should be using with athletes to make kind of some of the problem solving a little easier, and give you a process that might help you better.
But none of that negates the value of understanding physiological healing either.
Oh, absolutely.
That and I want to just emphasize that it underlies everything that he's talking about, the consideration of the physiological healing, but then within the constraints of that phase of healing, working on all of those levels of activity or function towards recovery.
Yeah, there's no getting away from the stages of healing.
Absolutely, I had to say it.
I appreciate that. Yes, and I appreciate that. There is no getting away. And think about that. Like I think of that with my exercise prescription. If somebody has let's say they're referred to you for a pronator strain. Okay, I am thinking in my head okay, what is going on here from a biochemical, a microbiome, all those things we learned for the CHT exam about wound healing, that applies to everything. So that's an excellent salient point, Marilla. Yeah, it's all based on that, and assessing and reassessing and adjusting and accelerating. And I say one thing you have to be really comfortable with treating athletes is knowing when to decelerate as well. Okay, everybody wants to get to point A to point B, as fast as we can possibly be, but to get people back safely and to be successful and to help them psychologically when they first have some pain. Okay, we may have to decelerate this, or it might not even be decelerated. We're gonna take a step to the side, because right now you have some inflammation. You're still in an inflammatory state, and so we need to change this a little bit. We're just gonna follow a different path. The one thing I say to them, I don't know if you can see me, but it never goes it doesn't go like this with rehab. And I say this to my general patients too. It doesn't go like this. It doesn't go like this. It goes like, this and that. And we're trying to get the peaks and the valleys to try to decrease those, the distances in between. And that's why it's important that you're able to make those adjustments for all your patients, not just athletes. And we learned that in fellows and other things. So
yeah, you're a wealth of knowledge. Thank you so much for your time today. I think everyone got a lot out of today's session. I wish we could go on because there's a lot to talk about here.
Anytime, Marilla.
Thank you so much. And thanks to everyone who joined today. I appreciate it. We have a few more of these left. Next week is a holiday week, so we won't meet next week, but I'll see you in 2 weeks, hopefully. So everyone have a great afternoon. And thanks again, Mike.